My name is Bernard Baune. I'm the Cato Chair and Head of Department of Psychiatry at the University of Melbourne.
My name is Peter Falkai. I'm the Head of the Department of Psychiatry at the University of Munich in Germany.
So what's the latest in strategies of treating depression? I think that's the big question. Is there any change or differences? What are the key?
Well, I think what we still have, or what we still end up, is a group of patients obviously not responding well enough to the treatment. I would, subdivide into 3 groups. So we are one group and they respond to a lot of strategies. So they are fine. We don't have to care with them. We have an intermediate group who partially respond, and then we have those ones who have difficulties in responding at all. And I think that is a kind of subgrouping where I think you need to sort of adjust your strategies to. Don't you think so?
Mm. I agree, and the difficulty we have in psychiatry is to identify this group prior to treatment.
Yes.
This is where we are working on from a biomarker point of view, from other clinical predictors, but we are not there yet. So therefore we are kind of left with our strategies applying to all patients group more or less the same at the moment, and that's where we get these differences and failures and successes in the treatment of patients with depression.
Well, on the other hand, I think you might raise in the upcoming discussion the paper by Uher, who actually then said, just don't look at the symptoms, but possibly look at other functional domains and include them. So I think it's an important point to actually understand when you initiate treatment quickly, who is improving and who is not. Because I think in the sort of everyday clinical work, it's important to judge that quickly and then change, either sort of completely change your regime or go for a, let's say, attenuated way. Because I think it's obvious the longer you take leaving people with residual symptoms, the more difficult it will become actually to solve the problem.
Exactly, yeah. That I fully agree with that. So we need kind of measures, whether it's a clinical measure or a functional measure, which tells us the early response. And what is early response? Often we talk about like 20% of change or 30% sometimes in the different scales. Whether that is sufficient, we don't know. Maybe we also need to include the patient perspective of what they respond to be important for them, whether they are functional outcomes or others. So the strategy one size fits all will probably not work. That's for sure. And sometimes when we have patients who have a very poor response pattern overall, more sort of intense treatments or combination treatments from the very beginning would be very useful in them as well.
Yeah, as you've pointed out, I think that combining maybe the view of the physician treating of the patient and then add biomarkers. I think if you look, for me, oncology is a good example, how they understood by adding biomarkers and stratifying, and then go into the subgroup and see what I can do better. And I personally think that, at least, I don't think that we are that far away. It is just that the sort of illness entities we look at, they seem to be a bit more difficult than what we might have in other medical disciplines. But I think even today, not having these markers, adding the patient's perspective, which I think we often do in the clinical routine anyway, but I think you need to stress that, might be very helpful to make sure that the early response or the early sort of improvement, let's say the 20% you just raised, is actually caught. Because I think that there is a lot of noise, and it might be that in the first 2 weeks when you sort of start with a new medication or a new regime, you might lost that, because there is sort of change over time, and it's difficult, you see the patient maybe once a week, maybe every second week, and then you capture within the half hour what time you have. I think you need to be very sort of cautious to have the necessary information in order then to decide what you do. Stay, change, and if you change, to what extent and what you do.
Yeah. And also the history of patients' treatment history, but also family history on response to antidepressants is an important part here in terms of predicting the response to a new treatment. Another, I think, challenging question in our field is whether we have a patient who has a first episode of treatment, and there the choice is slightly different from those who had previous antidepressant treatment episodes, and that gives us some information. But then we have those who have failed previous antidepressants.
The third group, yes.
Yeah, exactly. And we have to deal with them in a slightly different manner.
Completely agreed. As I say, this is subtyping and staging. As you say, stage whether it is an early phase of the illness, whether it's, I would say, intermediate when you have relapsing course, but you have treatment response. And then you have those guys who actually, where you don't have treatment response, or let's say you are far away from remission, and you still have residual symptoms. So what you do with these people? So then I think regimes like, certainly going for combinations have to be considered, because otherwise I don't think that you are able to, as I say, win percentages by percentages out of this group. If you're left with 20-25% of the patients, maybe a bit more, maybe less, it's, I think, difficult to actually target what is the best way. So possibly combining things like pharmacotherapy and psychotherapy and different pharmacotherapeutical approaches might be the way to go.
So identifying the potential change within the first 1 or 2 weeks is a key challenge, which we mentioned before. The question is, how do we get more sophisticated in that? So there are very practical issues here for GPs, for example. If they start a patient on an antidepressant, can they see them within a week again, or 2 weeks, or is sometimes left to 3 to 4 weeks? So I think we probably need to agree as a field that we need an early follow-up with the patient after initiation to see whether that treatment works to some degree or not. Because what we've learned is that a number of patients who have no response within the first 10 to 14 days will likely have no response after 4 to 6 weeks on the same antidepressant. So that focus on the early assessment and ensuring that, I think, is probably a key clinical challenge we have. The other point is on the youth mental health matter, which, it's not youth mental health we're talking about here, but about the different stages of the illness, about the early identification. And we kind of generalize maybe that concept by saying, regardless how old someone is, we need to be able to understand the stage in which that person is better and tailor the treatment according to the stage of the illness.
But it's as you point out, I think it's an important issue in depending on or in any stage of the illness to make sure to diagnose it correctly and then treat it. Well, one thing you just outlined was you said 2 to 4 weeks, and I think that's much more I would agree on, because I think if you, as you say, as a GP, it's unlikely that they on a routine basis will see the patient after 2 weeks. So 4 weeks, I think, might be something you can really go for, you have to go for. So rather ask for 2 and then you end up with 4 weeks, but then make a decision. And I think that's the other thing, is what I personally see from the clinical side, that often patients are seen, but then no decisions are taken. And I think we as a field need not only to say, well, there is this early timeline, don't miss it. And the second is, teach people, as you said, GPs, teach people what to do. Stay on the medication, combine it, change medication, or what you do. So what is appropriate? And possibly, if you are a GP at a certain level, you might find it's difficult for me, then refer to a specialist. At least in our world, again, that is not done on a sort of regular basis, which again, I think it's important that disciplines work together much closely.
Yeah. I think we raised a number of really, really crucial points. Many of them are not resolved; they are work in progress, which is fine for us as a field.